Our next speaker is Dr. Kendrick, the co-chair, and his topic is Deep Learning, Automated Diagnosis and Grading of Cataracts using Color Fundus Images, and it's called the Fundus Cataract AI Project. Over to you.
Thank you to my co-chair. So I'll be sharing about using fundus images to screen for cataracts using AI. So there's been a lot of work on cataract diagnosis and also screening using slit lamp technology. We wanted to propose something using fundus images. So this was sponsored by our health bureau in Hong Kong, but none of us have any financial interests related to this project, to declare. So worldwide incidence of cataracts is increasing, and in fact, it's actually burdening our public healthcare system because 90% of our patients in Hong Kong seek public care, but that's only taken up by 1/3 of our eye doctors in Hong Kong. And so we have a screening program, we have a triage program. It requires referral from a medical practitioner, but it's really designed to rule out patients with irreversible blindness. So it's patients who will have retinal detachment, have uveitis and ophthalmitis, but it's not very good at helping patients who have reversible blindness like cataracts. So if somebody presents with symptoms very related to cataracts, they tend to be given a routine appointment. And in Hong Kong, it can be 2 or 3 years. Post-COVID, it went up to 4 years before you're even seen by an eye doctor. So what we wanted to do was to use machine learning to be able to modify this and not need to use referral letters and be able to screen these patients in the primary care setting for cataract density. So if you look at a fundus image, it does give you more information than the back of the eye. So if you look at some of these images, some of them are not very useful to us normally to look at the fundus because it's very blurred, but that blurriness actually gives us information on the cataract density. So we hope that by training this algorithm, we'll be able to use it for cataract diagnosis and also stratification. So the first part was to actually train and validate the model. Second was to compare it to current practice. We used an automated DLS to screen for non-diabetic Chinese patients aged 50 and more presenting with chronic blurring of vision for more than 3 months. The idea was to exclude anybody with potentially acute or sight-threatening causes of visual loss. So we used a efficient net and we created the training algorithm followed by validation. And so the data set that we used for this was a data set that we had from a screening program that we ran for 5 years. From that, we took about 16,937 fundus images, again, from patients who are age 50 and above, Chinese or ethnicity. And we eliminated some of them due to very poor image quality and those that had cataract surgery already. And we divided this into categories such as normal, early cataract, and visually significant cataract. So the way we classify it was normal, meaning no cataracts, early cataract, meaning there is a cataract, but the visual acuity is better than 20/40, and visually significant cataract are those with a cataract and vision less than 20/40. And the reason why we have this cutoff is because the listing criteria in the public sector in Hong Kong is less than 20/40 visual acuity. So we split it up into training, validation, and learning sets as well. So if we look at the outcome, so this is the internal validation results. In the end, we used 11,544 images, and we split them into normal, early, and visually significant cataracts. Looking at the sort of the different mappings, you can see that the ROC, the AUC, is actually quite good. So normal versus others, early cataracts versus others, and cataract versus the rest. So sorry, when we mean cataract, we mean clinically significant cataract. And you can see that differentiating normal with cataract is probably the best with the AUC of 0.95. When we compared it to an external validation data set, so this was an additional 600 patients that we saw at our Grantham Hospital Eye Clinic, the AUC dropped slightly in terms of external validation, but it still did perform quite well, especially with normal versus the rest. And in fact, what we see here is actually differentiating clinically significant cataracts from rest is actually much higher at 0.96. So this is a heat map. It tells us that when we're looking at these fundus photos, the AI is actually using the disc and the macula as a reference point. So if it can see it very clearly, it knows there's no cataracts or very early cataracts, and if it's very blurry, then it determines it as clinically significant cataracts. So the real world usage is that we looked at an additional 638 patients going through this algorithm, and what this algorithm will pick up is that we'll have actually about 36.2% patients who are routinely referred with clinically significant cataracts already. So this does increase the workload of our eye clinic, but the first thing is that we need to identify more patients with cataracts in order to be able to increase our cataract workflow. So it does have a positive impact in that you don't need a lot of information, can be more objective, but the limitations is really single condition focused, and it relies on a larger capacity for cataract surgery in the public sector. So in conclusion, it means that machine learning can be able to accurately diagnose and triage cataracts, and we can democratize this in terms of new case booking and cataract surgery listing, and we can make this available in other primary care systems worldwide. So with that, I also want to invite you to APAO 2026 in Hong Kong next year. We'll be co-chairing this. And if you want to come again, I know most of the people here might be retina specialists, but we also are hosting ACS next year as well. So look forward to seeing you in Hong Kong. Thank you.
Thank you, Dr.